Philippines. So a community pharmacist who currently is a member of the CPS Exco, the Community Pharmacy Section of FIP Exco, and member also of the Executive Board, Western Pacific Pharmaceutical Forum. So currently practicing, as I've mentioned, community pharmacist. On now to the topic that is assigned. So I've just identified 3 learning objectives, and this is for us to review the pathophysiology of irritable bowel syndrome and outline and understand the typical presentation of irritable bowel syndrome or IBS, then describe the recommended management for IBS and what pharmacists could do as an intervention for this condition. For the discussion outline, okay, let's try to revisit and understand what is IBS and its risk factors. Look at the pathophysiology, what are the clinical manifestations, signs, and symptoms. Then try to take a look at how these are being assessed and diagnosed, and what medical intervention and management is done, and what pharmacists could do to advise the patients who may come to him for this particular condition. As I've said, let's try to revisit what this condition is. So it's a common gastrointestinal disorder involving an abnormal condition of the gut contractions and increased gut sensations, visceral hypersensitivity characterized by abdominal pain and discomfort, gas, bloating, mucus and stools, motility, irregular bowel habits that affects the large intestines or the colon. It is also described in some references as a mix of belly discomfort and pain, and trouble with bowel habits, either going often than normal, either because one has diarrhea or constipation, or having different kind of stool, which could appear to be thin, hard, soft, and even liquid. Now, it is said that IBS affects around 11% of the population globally. And this is prevalent to population with an age group 15 to 50 years old, and is affecting women 2 to 2.5 times than men, and men manifest diarrhea more than women, while women manifest constipation more than men. What are the causes for this? There are actually no exact causes being known. However, it is observed that psychological stressors is one cause. When one is depressed, having anxiety, sexually abused, or have post-traumatic stress disorder. It could also be caused because of altered gastrointestinal motility, altered visceral sensation, some dietary allergies or food sensitivities. And it could also be due to neurotransmitter imbalance, where there is a decrease in the serotonin levels of the individual. And presence of luminal infection is another cause of it, where 10 to 20% of patients experience this IBS symptoms following gastroenteritis. There are 3 types for this condition known. One is constipation predominant. This is when the person tends to alternate constipation with his normal stools. Second is diarrhea predominant, where the person tends to experience diarrhea first thing in the morning or even after eating. And the third is the alternating constipation and diarrhea. It is also called IBS-A or IBS-M. And what are the signs and symptoms? What are the clinical manifestations? So pharmacists has to take a look that these are the things that the individual would experience. It's known to us that symptoms could range from mild to severe, and this could occur at any age, but these are common in late age years. So what are these? Abdominal fullness and distension, loss of mucus from the rectum, sense of incomplete evacuation, gas and bloating, constipation, diarrhea, fatigue, and even sleep disturbance. And how are these being identified, or what are the diagnostic tests that are recommended to be done? There is actually no clear diagnostic marker that exists for IBS. Diagnosis always depends on positive clinical features and rolling out diseases by careful clinical examination and investigation. So a complete history taking, including psychosocial factors such as stress and anxiety, is needed to be taken. And of course, physical examination is done, and in some cases, barium enema is being done. Other ultrasound could be also recommended, stool examination, upper gastrointestinal study, and even colonoscopy and sigmoidoscopy. So these are the tests that are being conducted or being done to really determine what the condition of the patient is. So for the diagnostic criteria, there is the use of the Rome-3 criteria for irritable bowel syndrome identification. One is the observation of a recurrent abdominal pain or discomfort that would happen at least 3 days in a month for the last 3 months. And this condition is relieved with defecation and oftentimes associated with change in frequency of stool and consistency of stool. And second, any 2 or more of the following is observed to be experienced by the individual. There is altered stool frequency, consistency, and passage of mucus, and abdominal bloating or distension. So when these are observed in the individual, then this would be indicative of irritable bowel syndrome happening in one. And there are red flag signs and symptoms. Now, I've included this because while we do encourage how we should immediately manage one who is into this condition, we also have to be aware, and we should know when we should refer the patient immediately to a medical practitioner. So these are the red flag signs and symptoms that we have to watch out for, or that we have to ask our patient if it is happening. So proper referral could be done. One is unintentional and unexplained weight loss. If this is happening, then we have to be already alert, or we have to already take this as one indication that we need to do some referral already. Rectal bleeding is happening or is experienced, and then we need to see the history of the patient or the individual, or whether there is in the family one having rectal or ovarian cancer. And then anemia is another one, abdominal mass, rectal mass, and if there are some inflammatory markers that is observed to already be indicative for IBS. To roll out organic causes, so these are the things that are to be done. So to really make sure that all those that we see in the red flag would not come up to be a more serious medical condition, but irritable bowel syndrome. Complete blood count is recommended. Erythrocyte sedimentation rate, C-reactive protein. We know that this is the kind of protein that is produced by the liver, and when this happens, this is indicative of the individual to be on a medical condition that is already driving inflammation. Stool examination for ova and parasites, and of course, antibodies for celiac disease. So this is a type of autoimmune disease, and we need to really take a look at what the results of this test are in order to roll out anything that is to be interpreted more serious than irritable bowel syndrome. And management for this, how should this be managed? Of course, we have to always bear in mind that the goal is always to relieve the symptoms. And we need to reassure the patient and do some psychological support, because this might would create in the mind of the patient of something more serious happening in him. So it's important for the pharmacist who is in the front line, easily accessible by many, to be there, capable of reassuring the patients that it is just that irritable bowel syndrome. Dietary advice is another thing that we have to do. There should not be any dairy products that the patient would be taking or the individual would be taking. Food and beverages. Yogurt could be advised to be taken, but not much. And then no medications containing fructose and sorbitol, no excessive caffeine, no gas-forming food like brown beans, Brussels, cabbage, cauliflower, and onions, and high fiber diet. And dietary advice, we can tell the individual to take probiotics, but it has to be a diet that is low in food maps, meaning the diet should be low in any fermentable oligosaccharide, disaccharide, monosaccharide, and polyols. You need to remember and be reminded that these are the short chain carbohydrates that are poorly absorbed in the small intestines and fermented by bacteria in the colon to produce gas. And if patients is having diarrhea, she could be given loperamide or an antispasmodic to control the colon muscle spasm to reduce abdominal pain could be given. Hyoscine in-butyl bromide could be the medicine. Anticholinergic agents could be given, dicycloverine, which should be given 30 minutes before a meal to control colon muscle spasm. Now, in some instances, antidepressant is given to reduce peripheral nerve sensitivity. Psychotherapy is important because it's found to be effective to 2/3 of the IBS patients who do not respond to standard medical treatment. Cognitive behavioral therapy, stress management techniques, acupuncture, and hypnotherapy. So these are the management of those that are having IBS. For patient counseling, I'm about to end. It is important for the pharmacist, may I reiterate, to reassure the patient. And this is the most successful form of treatment for IBS. Many are concerned that they are developing cancer. We have to remember that more anxiety, more colonic symptoms. Explain the functional nature of the disorder and how to avoid obvious food precipitants. Emphasize on expected chronicity of symptoms with periodic exacerbation. And we have to make clear to the client that the bowel responds to stress, food, and medications. So shy away from stress, shy away from precipitant food and medications. With this message, we need to understand irritable bowel syndrome well as service provider for patients and how this should be managed, as this will help us pharmacists provide the needed support that our clients need. Pharmacists can provide clients and their families the advice for the various options available in the treatment of irritable bowel syndrome.